All right. Hello, everyone, and welcome. Thank you for joining us today. I'm going to turn it over to the presenters in just a minute, but before I'm going to go over a few things about the platform and let you know how you can interact with the presenters today. The chat box will be available throughout the session, so please feel free to type in any comments and questions you have, and the facilitators will be monitoring that. Please also feel free to raise your hand and unmute yourself if you would like to ask your question aloud. There will be time at the end for Q&A, and we want to encourage everyone to participate. We will also have an evaluation towards the end of the presentation today, so please feel free to click on that and let us know how today's presentation went, and also let us know if you have any ideas for future presentations or any TA requests. With that, I will turn it over to today's presenters to introduce themselves.
Hi, thanks so much, Alicia. I'm Tony Rosen. I'll introduce myself first, and then my colleagues will introduce themselves. We're all going to sort of co-present today, and we really appreciate the opportunity to talk to you a little bit about our program. I'm an ER doc and assistant professor of emergency medicine at Weill Cornell Medical College and New York Presbyterian Hospital in New York City. And my colleagues and I are going to talk today about the Vulnerable Elder Protection Team on which we work together. Alyssa, do you want to introduce yourself?
Sure. Thanks, Tony, and thanks, Alicia, and everyone for having us. I'm really excited to present with all of you. I'm the supervising social worker for the Vulnerable Elder Protection Team, or VEPT, and I've been with the program since its inception about 4 years ago. And I'll pass it over to Elaine.
Hi, I'm Elaine Gottesman, and happy to be here. I'm a social worker on the Vulnerable Elder Protection Team. I am not an assistant professor of emergency medicine. And I'm
no, neither are we.
Just made me laugh.
Soon, hopefully. I'll start by sort of focusing a little bit on learning objectives. Hopefully this presentation is helpful. Please interrupt us with questions. We've tried to keep it short enough that we'll have plenty of time for questions and further discussion. But our learning objectives are to understand the role that emergency departments can play in investigating and intervening in elder abuse cases. That's really the core of our program. And to explore key protocols and multidisciplinary linkages that we use to address elder abuse at the Vulnerable Elder Protection Team, or VEPT, to describe the impact that we've already been able to measure in the VEPT model, and to gain insight as to how our model can maybe work for E-MDTs and be adapted based on existing community needs. So that's a lot, but hopefully we're able to today give you a little bit of information about what we're doing, and you can think about how that's something that might be applicable, or at least elements that might be applicable in your community and for the clients and older adults that you serve. Okay, I won't read this disclaimer to you, but in short, thank you very, very much to the Office of Victim Crime Victims Justice Programs in the Department of Justice for supporting this presentation and the National Elder Abuse MDT Training and Technical Assistance Center, and the opinions that we're going to present, our opinions, and not those of the position of the Department of Justice. So with that, I'm going to hand it over to Elaine. And Elaine, I'll stay on so you can let me know when you'd like me to advance slides.
Sure. So we all know that the aging if you can go to the next 20, the aging population is growing. The U.S. adults age 65 and older will double to 83 million by 2050. Next. And the oldest old, which is 85 and older, will triple by 2050. If you go to the next. And so relevant to our program at the hospital, older adults are increasing how frequently they seek care in the emergency department. So setting the stage here about elder abuse, we all work in elder abuse, but we know that elder abuse is common and has serious consequences. Next, thank you, Tony. 10% experience abuse or neglect each year. And we know that victimization increases risk of mortality, nursing home placement, dementia, and depression. We know that it's under-recognized and underreported. And as few studies say, as few as 1 in 24 cases are identified. And we know that actually 9 in 10 incidents involve family members as perpetrators. Next, Tony. And they are often adult children or spouses. So just setting the stage, let's define elder abuse. We all work in this, so we know this, but getting on the same page, it is defined as mistreatment of an older adult, age 60 or older. Thank you, Tony, by a person in a position with an expectation of trust, or when an older adult is targeted because of their age or disability. So it may include physical abuse, sexual abuse, neglect, psychological abuse, financial exploitation, there's one more, and many victims suffer from multiple types of abuse.
And so from our perspective, the ED and hospital might be an important opportunity to identify elder abuse and intervene. In fact, evaluation by a healthcare provider may be the only time that an abused older adult ever leaves their home or the environment in which they're living. And the limited research that we have suggests that abuse victims are less likely to see primary care providers and more likely to present to an emergency department. And frankly, if you present
Did we lose Tony?
with a broken arm or with an acutely managed acute injury.
Oh, Tony, I think we lost you for a minute, so you might want to just go back where you said frankly about the acute injuries.
Oh, thank you for letting me know. Is my internet connection okay now? Or is everyone able to hear me now? Great, so I apologize. What I was saying was that, frankly, if you present to your primary care physician with a broken arm or with an exacerbation of congestive heart failure and you're having difficulty breathing, then they're likely going to send you right to the emergency department because we typically manage acute injuries and illnesses. So the ER might be a really good place to identify this. And here's another reason. If you think about it, the ED is sort of a unique environment. We have varied disciplines observing a patient, not just a doctor, but also nurses, techs, clerks, patient escorters, radiology techs. And no matter what we do, you're usually there for several hours. So it's an evaluation that's typically prolonged. Also, the ER, even in a city like New York, the ER is often the only place where resources are available 24/7. Sunday morning at 3:45 in the morning, the ER may be the only place that has resources. But despite this, EDs seldom identify or report elder mistreatment. In fact, research that colleagues and I have worked on suggests that elder mistreatment is reported in the ER 1 in every 10,000 ER visits. So this is something that's happening to maybe as many as 10% of the population, and it's identified 1 in every 10,000 times. So why is this not happening? Well, patient may be denying it. There may be ambiguities around decision-making capacity in victimized older adults. There's probably not available resources for a streamlined response. There may be lack of awareness or inadequate training, lack of time to conduct a thorough evaluation. And I want to focus most importantly on that last one, because I'm not an ER doctor, I'm a busy ER doctor. And it turns out that of all of these, lack of time is the biggest challenge. And I want to sort of talk a little bit about what it's like to work in the emergency department. One of the things that makes the ED different than other types of medicine is that ED providers are typically caring for multiple acutely ill or injured patients at the same time. And if you think about it, and we realize this as doctors, that it's a triage process. And so any time that we spend assessing or caring for one patient is necessarily time that we're not spending with the 14 others under our care. And so if you think about it, one of the things that we teach our colleagues, and that frankly you go to your local emergency department, right, likely, and teach the medical providers in your community, is that you got to separate this older adult and that you got to ask them some questions and make sure that you're not missing something. Well, if you take the time to do that and you find something, then that's even more time that you're not spending with the other 14 patients. And so in some ways, oh, by the way, 2 more patients just arrived because there's always a bus accident. So while you're busy trying to work on this one patient who might be a victim of elder mistreatment, you now have 17, 18, 20 other patients that you're not able to focus on. And so if you think about it, many ER providers sort of don't want to know. In some ways, you're disincentivized from assessing for this. After all, if someone comes in and says, you know, I fell, my elbow hurts, or the person standing next to them says they fell, their elbow hurts, well, let's get an x-ray of the elbow and let's get them out of here. I got 15 other patients to see. Even if you're like, well, they're kind of an unusual relationship between the son and the father, but I'm busy and let's get this rolling. And so as you can hear, there's often disincentives to focus on this in an emergency department setting. So if you think about it, and I'll pause for a second and talk a little bit about our program. If you think about it, child abuse has some of the same issues. ER doctors are not necessarily experts in caring for child abuse victims, and I can assure you that if you identify a potential victim of child abuse, that's several hours of phone calls. And so how have folks managed it in ERs for child abuse? Well, what they've done is they've created child protection teams. These teams exist in over 1,000 emergency departments, every emergency department I've ever worked in. And if you're an ER doctor and you think, gosh, I'm not sure that's a fall off the monkey bars. That feels to me, or I'm concerned that there might be non-accidental injury. Well, you can just press a button. You can just activate the child protection team, and they'll come to the bedside, and they'll evaluate the patient, decide whether additional workup is needed. They'll help with the phone calls, and you can turn your attention back as an ER doctor to the heart attacks and strokes and ectopic pregnancies that are our area of expertise. And even though there are, as I mentioned, over 1,000 child protection teams, and these have existed since, believe it or not, the 1960s and 70s, we knew of no ED-based elder abuse response team. So we created one. As Alyssa mentioned, she and I started this program in April of 2017 after a pretty extensive development process. And here's what we do. We're a consultation service available 24/7 because the ER is open 24/7 to assess, treat, and ensure the safety of elder abuse and neglect victims while also collecting evidence when appropriate and working closely with the authorities. And our goal was to increase identification and reporting by our ED colleagues while simultaneously decreasing the burden on them. We were hoping that if all they had to do was press a button, and you can see the button in the top right corner, if all they had to do was press a button, they might be more willing and interested in assessing for this. And also, if they were concerned, they could just hand it off to us. And if you're wondering whether that feels a little like a copy in some ways of child protection teams, the answer is absolutely yes, and on purpose. So what do we do? Well, when we're activated or consulted, they actually place a consultation, just like a surgery consultation or an endocrinology consultation, and it goes to both a medical provider and our VEPT social worker, either Elaine or Alyssa. And we work together with the medical team, the primary medical team, and we also involve, as necessary, our inpatient geriatrics colleagues, emergency psychiatry, our radiology colleagues, security, patient services, and hospital administration and legal. And we do a full medical evaluation from the perspective of elder mistreatment. We do that head-to-toe examination that might not be customarily done in a busy emergency department hallway. We explore in detail the patient's home situation, and we attempt to get collateral from physicians, family members, and others in the community. Also, we take photographs, and we recommend additional laboratory and imaging testing. We assess for capacity. And I want to talk a little bit about this. We also involve psychiatry for this, and this turns out to be a really important part of our program and of thinking about assessment and intervention for elder mistreatment in a hospital-based setting, is that we've certainly had cases where the older adult will say, you know, Dr. Rosen, you're right. I'm not really getting the care that I need, and my son hit me in the face last night, but I want to go home. And if you think about it, that can be really challenging for children. And I've had this happen to me. 8-year-old says, Dr. Rosen, mom hit me. This isn't a fall off the monkey bars, and she locked me in my room without food last night. But I want to go home. I love my room. I like home. I love my mom. We say sorry. As a society, we've decided we're not going to let you go home until we're sure it's safe. But when that same patient returns at age 25 and says, you know, you're right. This bruise on my belly is not because I'm clumsy. My partner hit me, and he threatened me with a knife last night, and I'm really concerned. But I love him, and he said he's going to change, and I want to go home. We say we're open 24 hours a day. This can get worse and be life-threatening, and we want to help you safety plan, but you have a right to make this decision. But if you think about it, I've cared for lots of 95-year-olds who absolutely have the capacity to make that decision, and plenty of 70-year-olds who may not. 70-year-olds who might have 6 months ago, 2 weeks ago, an hour ago, and might not. And so thinking about capacity, which I know is an important thing in the work that all of us do, can be acutely important in an emergency department assessment. And so we work closely with our psychiatric colleagues. We determine acute security needs. We can actually remove the abuser from the bedside if necessary. The real focus of our evaluation is the work of Alyssa and Elaine, who do comprehensive social evaluation and think about what might be an appropriate and safe home environment. We notify patient services in our hospital. One of the big challenges in elder mistreatment, it turns out, and I'm going to respond to Ms. Ball's question in just a moment. But first, I'll mention that what's a real challenge in our field is that often the healthcare proxy or healthcare decision maker is the abuser, is the person standing next to the bedside trying to direct care. And so how do we manage that? And so we have access to our patient services, administration, and legal and even ethics, all of whom are on call 24 hours a day to assist in the hospital. And so we can and do assess patients in that fashion. Now, Ms. Ball asked the question, is elder-to-elder abuse in an intimate relationship ever been presented to your team? And the answer is absolutely yes. I actually got a question about this in Colorado just last week from emergency physicians. And a couple of thoughts about elder abuse in intimate relationships. The first is that, as Elaine mentioned when she began the presentation by defining elder abuse in New York State, we define elder abuse at age 60. Some states define it at 65. Some states even add additional protections for older adults greater than 70 years of age. But the reason I bring that up is that the law regards intimate partner violence slightly differently after a certain age. However, many elder abuse cases are in fact what we might refer to as intimate partner violence grown old. If you've been physically abused by your intimate partner for 30 years, nothing magically changes on your 60th birthday. It turns out that your partner can get charged with more crimes on your 60th birthday than he or she might have been charged with on the previous day, but the phenomenon doesn't change. It's intimate partner violence grown old. However, there are really several, but I'll focus on two other typologies of elder abuse in intimate partners, among intimate partners, that are important to think about. The first is in intimate partners, both of whom have either physical or cognitive impairment or both. And these are intimate relationships that might have been loving and without abuse for 50 years. And then both partners start to suffer decline, or one partner starts to suffer enough decline that he or she requires care from the other, and the other is either unable or unwilling to provide the care, or gets frustrated in attempting to provide the care, and abuse, neglect, and exploitation can occur. Also, unfortunately, and I think we're all experienced in this, there are intimate relationships that develop between an older adult and another person, often a much younger other person, who may be engaged in the intimate relationship primarily or exclusively for the purposes of exploiting the older adult. And so that's another challenge. So the long answer to your question, Ms. Ball, is absolutely yes. However, it often is different phenomena that often require or benefit from different types of interventions and different approaches. I'm going to pause for a second and mute myself to see if I've answered your question. I hope yes. I'll continue. We also, as part of our work, can report to Adult Protective Services and the police, involve multidisciplinary teams. And from our perspective, we've built up very strong, very collaborative working relationships with all of these groups. And that really has an impact on our ability to do our work. And it really means that we can effectively provide a higher standard of care to these patients than they would have been getting previously. We also coordinate with our geriatric inpatient and outpatient provider colleagues. Alyssa?
All right, so we think we're meeting a need. Based on our first 2 years, we had 200 ED activations, so that's about 2 per week. And I will say, since we've expanded our program, which I'll get into in a little bit, I would say that that number is probably a bit higher at this point. And we also, oh, sorry, go back, Tony. We also had 55 inpatient activations. So when we first designed the program, we were responding only to ED activation. So the patient had to be identified as a possible victim of elder mistreatment while they were in the ED or the ER. But we realized that people heard about our program, thought we were really helpful, and the medical teams on the inpatient units really wanted support when these cases got identified later on in the hospitalization. So I provided informal support for those 55 cases. Next. So based on our initial couple of years, we saw mostly physical abuse and neglect, though 50% of our patients had more than one abuse concurrently. And as Elaine had mentioned, this supports the data, as we saw mostly adult children and spouse or partner as the perpetrators, but paid home caregivers were common as well. So after our ED evaluation, we found that, if you could click one more time, Tony, 61% of our patients seen, we had high or moderate concern for some form of mistreatment. And that's about what we would expect. You know, we wouldn't think that every time we were consulted, we would have high or moderate concern for abuse, because otherwise it would mean the teams were able to correctly identify it and they wouldn't really need us so much. So we wouldn't expect that every single case was a confirmed abuse case. A lot of times we would come and do bedside evaluation, get a lot of collateral and be like, you know, thanks so much for consulting us. We totally see why you were concerned, but we found out this story from the neighbor or whatever, and everything kind of seems okay. So this is kind of how our cases broke down. And among those 61% with high or moderate concern, we, if you don't mind clicking, were able to have a change to the living or housing situation in 58% of cases. And of those 58%, so what that means is discharge to a different home, rehab, a nursing home, or in 33% of those cases, a shelter. And for an additional 23% of cases, we were able to implement new or additional home services. So what that typically means is putting in a home health aide that they maybe didn't have any help at all, or requesting an evaluation from their current home care providers to increase the hours. So we had 81% with some sort of change to their home living situation. And only 4 of our patients returned to the ED for a mistreatment related issue, which was really impactful for us because we speculate that a lot of these patients are heavy users of the ED system, and are kind of cycling in and out of the hospital, and people aren't picking up on these social issues that are contributing to their presentation. So we hope that our program, and we're going to look into this more as our program continues to develop and be evaluated, but we hope that, you know, this continues, this trend. And we received funding that went into effect in October 2019 from the New York State Office of Victim Services to expand our program beyond the ED, so that we were able to respond to those 55 inpatient consults, which are now much more than 55. We were able to bring on Elaine and a program administrator to help with, you know, some of that and provide extra support to me and Tony and the rest of the team, so we can have a full response to the inpatient consults and also follow patients throughout their hospitalization. And we also are now available via telemedicine at our LMH, which stands for Lower Manhattan Hospital location. Back to you, Tony.
Thanks, Alyssa. And I wanted to highlight a few of the partnerships, or rather we wanted to highlight a few of the partnerships that we've built in our program that are things that you may want to think about. The first is the ED, or EMS. I remember when I first got into thinking about elder abuse and identifying elder abuse in the emergency department, one of my friends and mentors, who was a physician much older than I, said, "Gee, Tony, sounds like an interesting topic, but it's not like we do home visits on these patients. We're ER doctors." But if you think about it, almost all older adult patients that present to the ER, or at least a large fraction, they just had a home visit about 10 minutes ago from EMS. And so ultimately, EMS realistically might be able to really contribute significantly to our ability to identify elder abuse. And one thing that's unique about New York City is that the big hospitals actually run ambulance fleets. Our hospital has the largest ambulance fleet in the country, largest private ambulance fleet in the country. And so we actually have collaborated with our EMS. And so if they assess a patient in the home and are concerned about elder abuse, obviously we don't want them to have a patient with chest pain to drive by 7 hospitals, but they'll bring them preferentially to our hospital and communicate their concerns to us so that this patient can receive better care. Also, through our work with the multidisciplinary teams, we recognized that our adult protective services and other community-based agency colleagues were having a big problem. They would often go into a client's home and recognize that these circumstances were immediately unsafe. And their protocol at that time was call 911. And what would happen is that the patient would get, an ambulance would arrive and typically take the patient to a local hospital. And by the time the patient was seen by an ER doctor 4 hours or 5 hours later, the ER doctor would say, "Why are you here?" And the patient would say, "I don't know." So the ER doctor would be like, "All right, well, let's get you home." And so the patient would go right back into the unsafe situation. And so we designed a protocol for APS and other community-based providers to actually call our ambulance service, which, by the way, also can be a 911 response, involve the police if necessary. And rather than calling 911, they call our ambulance. And the ambulance will go anywhere in the city and bring them preferentially to our hospital. Again, assuming that there's not a medical emergency precluding a longer transit time. And then a couple things that are key about this intervention is that the adult protective service worker comes with the patient in the ambulance, and we meet them in the emergency department and discuss the case together and make a plan. And as you can imagine, our adult protective services colleagues think this is really a game changer for them and their ability to protect their clients. And I wanted to highlight a little bit about the New York City Elder Abuse Center. I think a lot of you on the call are very familiar with the New York City Elder Abuse Center, but we're very lucky to have them as partners in all the work that we do. They have multidisciplinary teams that meet several times each month to discuss the most challenging cases. And they include representatives from adult protective services, medicine, nursing, social work, civil law, victim advocacy, criminal justice, and law enforcement. And they absolutely include members of our program. In fact, I believe Alyssa attended one of those meetings just today. Additionally, the New York City Elder Abuse Center provides case consultation for professionals if they're unsure how to proceed. And the reason I bring this up at this point is that for us, we're an ED-based team. And here's how we work most closely with the community-based multidisciplinary team that I think is what is typical and what it is that many of you work on and lead. We really work with them most closely in 2 ways. The first is if we've got a patient in the hospital that we don't know what to do about, that we're not sure what the best next steps are, that we're not sure what the resources are, we bring it to the team. And one of the nice things about bringing a case to the team while the patient is in the hospital is that the team's got a lot more flexibility of what they can recommend and a lot more ability to intervene effectively. Also, conversely, and this is one of the reasons we designed the VEPT program, is that sometimes there's a case that's discussed in the MDT meeting, the community MDT meeting, and someone says, this patient is really unsafe. They need to go to the ER right now. We need to call 911 immediately. And so ultimately, rather than calling 911, the team can contact us, give us appropriate sign out, and the benefits of what the team has already discussed will be relayed to us, to our program, and to the folks caring for this patient when they arrive in the emergency department. Also, the New York City Elder Abuse Center runs a really exciting helpline for concerned persons. They've recognized that the folks that live in the building with an older adult, or that are a best friend of an older adult, or are a informal caregiver of an older adult, are often trying to protect them from abuse and mistreatment and really struggle to do so. And so they need support, and this new innovative first of its kind helpline is doing that. So we've been doing a lot of talking. I apologize for that. Hopefully it's at least somewhat helpful. But we've designed some websites. The first that may be useful is a website about our program. And so if you're in a community where you're like, gee, I wonder if the ER folks might be interested in something like this, you're welcome, of course, to point them to our website, and they can read about our program, about how our program was started, what we do, how we approach cases, and some of the impact that we've been able to demonstrate. Also, we designed this, elderabuseemergency.org. And this is hopefully useful for those of you, and I suspect it's many on the call, who actually go to local ERs or go to local hospitals to present on elder abuse. You might be the elder abuse expert for your community. You might be the elder abuse expert for your state, or you might be the elder abuse expert for your tribal nation. And so you're the one that does the every other year lecture to the emergency department doctors. Well, hopefully this website will help them. When I do these kind of presentations, and I do them a lot, I say, you're probably not going to remember what I said. And in the ER, we need to know a little bit about a lot of things, and we kind of need to know the information when we need to know it. And so as a result, we built this website. And the idea is this website is something that you can use while you're on shift as an ER doctor and look and say, oh, I forgot about this, and what am I supposed to do next, and who do I call? And so this is a resource with information, protocols, and resources for ED, EMS, and hospital providers. And so that's something that you're welcome to look at. Perhaps it may be helpful to you, but it also may be helpful to medical providers that are either participating in your community-based MDT or that you're presenting to and trying to partner with. And we've really tried to partner very closely with and really had a lot of luck partnering with lots of different organizations, from the PD to the district attorney's offices to judges to adult protective services. And we've presented at meetings and grand rounds throughout the city. And one of the things that we've discovered is that when doctors and hospital-based social workers get interested in a topic like this and offer to collaborate, there's a lot of interest in collaborating. And so I think that from the perspective, if many of you on the call who are listening are not hospital-based social workers or medical providers, recruiting those folks into your group, empowering those folks may be a really useful step. And if you think we can be helpful in collaborating with them or reaching out to them, let us know. We're lucky enough to have gotten some recognition from our work. And what we're most excited about and most proud of, proud is the wrong word, and excited is, I suppose, even the wrong word, given the type of field that we all work in together. But as Alyssa mentioned earlier, we were able to expand our program by receiving funding from the New York State Office of Victim Services. This is the actually a federal grant funded funding agency that actually goes through individual states to fund violence prevention programs and programs that support victims of crime. And so if you think about your own community, many of the domestic violence shelters and other crime interdiction programs are sponsored by this part of the Office of Victims of Crime. Obviously, the national version of the Office of Victims of Crime is what's supporting the MDT Training and Technical Assistance Center. And more, our colleagues at the various components of the OVC are recognizing elder abuse as an important, underfunded, underaddressed type of crime. And so we have colleagues and friends at the University of Colorado who thought our VEPT program was interesting. and thought that they could do something similar in Colorado. And so they applied for and received a very large grant from the Colorado Office of Victims Programs, or for Victim Programs, which is their sort of analogous agency to our Office of Victim Services in New York. And they've started the second of its kind ED and hospital-based elder protection team. And we were lucky enough, I actually was in Colorado last week for the first meeting of the two teams to share information, strategies, and to ensure that we're moving forward in a way that's meaningful for the field. So for us, that's really exciting, and means that hopefully this is a model that can be grown and disseminated. And so with that, I apologize. Elaine has a new baby, but we didn't add, we should for the next time add Elaine's new baby to this photograph. But on behalf of Alyssa and Elaine, thanks very, very much for inviting us to give this presentation. We hope it was helpful and that that creates things for you guys and to think about in your own communities, and potentially elements that you might be able to take for the care of older adults that you do. And most importantly, as I think Alyssa and Elaine and I try to say at the end of every presentation that we all do, we know this work is not easy. And so thanks very much for all that you do for the vulnerable older adults in your community. And with that, we're happy to take any questions.
I have a question. First is, let me say that I just appreciate and am amazed by the work that you guys are doing. I would love to see something like this replicated in our community. My background, my most recent position prior to working as a coordinator was with the medical forensic program. So I appreciate you so clearly articulating all of the limitations and barriers and reasons as to why we don't ask more questions, we don't do more digging in, we don't end up reporting. And one of the barriers that we were really stuck with is we were not having emergency department staff call us, because if we responded, we would tie up a bed sometimes for a couple extra hours, sometimes maybe even a day, trying to figure out what was going on, especially if the needs were really complex. It took us a while to vet out. And especially right now, in the midst of where we're at in the world, it's a hard sell sometimes to even just do the right thing, even though you're taking the workload off of them. Hospitals are really concerned about throughput. Like, I know that was a major issue where I used to work, because they were trying to sell the hospital, and the more people they could get through, the more, it became a kind of political and financial. So how do you navigate that portion?
It's a great question. That's an often asked question, as you can imagine. And I have a few thoughts about it. Ultimately, from our perspective, I think that we really want to avoid, I'll actually answer it in several ways. The first thing I'll say is that I think that in emergency medicine, our true job is to identify life-threatening things that aren't obvious. That's what we pride ourselves on. When you come in with a gunshot wound in your chest, I promise I will take care of you, but most ER doctors can manage that. The goal for an ER doctor is to manage something or to recognize something that might be life-threatening, but is not obvious. And that's elder abuse. And I think that the attitude that people have now about elder abuse is the same attitude that they had about child abuse and intimate partner violence 30 years ago. We're 30 or 40 years behind in that. However, our hospital has really supported our program very, very well, and has really been interested in growing our program. And why is that, given these competing priorities? And let me tell you how we approach these, because we've, as you can imagine, Ms. Hollenbach, we've been to length of stay meetings, and we've been to those kind of meetings throughout the time that our program has been in existence. And here's the first thought. The first thing is that there is in the hospital world something called a social admission. And no one likes that. And hospitals really try to avoid social admissions. We've changed the nomenclature in our hospital. We call them, in elder abuse, safety admissions. Because no one wants to release a patient from the hospital who might be unsafe at home. And so as a result of that, we've gotten much more buy-in. In addition, we find that even when we start recognizing this, it's a very small number of patients relative to the numbers that our colleagues are dealing with on the length of stay committee. And in fact, when we presented at the length of stay committee about our cases, the CMO of the hospital said something like, you know, we ought to be able to shave 1/10 of a day off of a lot of other patients so we can support programs like this that really help the most vulnerable in our community. And so, does that take time to build up that goodwill? I suspect that it can. But the possibility is there. Additionally, we actually developed a strategy that I don't talk about typically in these lectures, but I think it's useful to answer your question. Our adult protective services in New York City has what's called a do not discharge letter. And they can fax that to emergency departments. And they often have done that in the context of when they call 911. But guess what? I work in an emergency department. And that emergency department fax machine is full of stuff that no one ever looks at. And when we started getting these, APS told us they've been sending them to our emergency department for like 20 years. None of our social workers had ever seen one. None of our doctors had ever seen one, ever heard of it. But it turns out that we actually changed the approach. When APS was concerned about being able to care for the patient safely in the community, we said, we want you to send us one of these letters. And we turned around and sent that letter to our legal department. And some of the legal department's like, well, no, we can't send them home now. And that also, and again, I apologize for the very long answer to your question, but that also offers a future pathway that we all think is relevant, though we're not here yet. Ultimately, if our colleagues in adult protective services, for example, feel that they cannot protect a patient in the community, and the only place in the community for that patient to be is the hospital, well then, the Office of Family and Child Services maybe ought to pay for that hospitalization, because that's where we are getting. Does that make sense? So from my perspective, and it turns out in some counties in the United States, believe it or not, that happens. Not in any county I've worked in. But I think that ultimately, that's where we want to get. I don't think that any of us believe that the hospital in the long term is the appropriate place for these older adults. However, in the short term, in many communities, it's the only way we can keep them safe. And so I think that realistically, there are opportunities to improve this. Also, and then this is I apologize. I promise the last part of my answer to your question. Also, I think that adult protective services and the ER often have, I don't want to say a low regard for each other, but not much insight into the other's responsibilities and role. And so all it takes is a few ER calls to nowhere on evenings or weekends, and the same patient presenting 3 days later with the same problem for the ER to get discouraged about adult protective services. And all it takes is a few times for the adult protective services to send a patient for the ER only to find them back in the unsafe situation 6 or 8 hours later for APS to get discouraged about the ER process. And what that really needs, and what actually DOJ is starting to support, is more collaboration. The ERs and APS, and I don't mean to specifically focus on APS, I think we can talk about all community-based organizations, really need to understand each other's incentives and understand how best to work together. And as I like to say it, how best to work together on Friday afternoon, because that's when all these cases come, Friday afternoon at 4:15 in the afternoon. And so ultimately, how can we work best together? Is there someone I can call? So rather than admitting the patient in the hospital, I can send them home and feel confident that there's going to be someone that can see them Monday morning, or that I can call and say, you know what, I got to admit this patient. I know the hospital's not going to be happy, but I think I can now have enough information to document clearly why that's the only safe approach. And again, I completely agree. I'll tell you, I'll be honest with you. Some of my colleagues like, Tony, I feel like you keep patients in the ER too long. You know what? That's what geriatric emergency medicine is all about. Older adults can get worse a lot quickly, can get worse very quickly. And thinking about observation status and finding out about options is a really important part of the care that we provide to older adults. And so for me, and again, I promise this is the last part of the answer, and I think we need to change the culture to some degree of emergency medicine. In my ER, after 3 or 4 hours, you got to make a decision, admit the patient or send them home. And that sometimes creates bad decisions on both sides. On one side, we're admitting the patient because we're just not sure we can, it's 4 a.m. and I can't get a hold of anybody. I'm not sure the patient's going to be safe to go home. I admit. And then everyone gets grumpy about that. Or the reverse, one of the hospital administrators talked to me 6 weeks ago about a similar case. So it's 4 a.m. and I'm not happy, but I don't want to get talked to another hospital administrator. So I send the patient home and something bad happens at 4 a.m. Ultimately, what should change is that in many ERs for this kind of patient, we should say, you know what? It's 4 a.m. Let's wait until 9 a.m. It's okay. We're taking a bed. Guess what? Patients are in hallways and ERs all the time. And at 9 a.m, we can make some phone calls and decide if it's safe. At 9 a.m, maybe our social worker comes in, maybe our care coordinator comes in and can help us make sure that either home is safe or that we're admitting only after we've exhausted other options. And even though we don't have one in our hospital, I feel like geriatric observation units, which is not hospitalization, but no longer the ER, offers a lot of opportunities to do this properly and to do this in a way that is community collaborative. And so hopefully in that very, very long answer, I've given you some tools to go back to your own hospital systems and your own communities and to think about, well, gee, do you have an OB status? So maybe we can move these patients into OB status. And my pitch is I can maybe avoid an admission. You can move them to OBS, call me, and maybe I could get enough collateral that you can safely send them home on hospital day 0.5 and avoid an admission. So maybe that's how you can be helpful to them. That's one option. Or, hey, one of the things we're doing is protecting you from, I like to say it, from the New York Times. All it takes is one person that you send home and some terrible outcome happens, and that hospital administrator is not going to be happy with the case. And so ultimately, that's another thing that we do. And then again, of course, we are people that help people. That's the job. That's what we signed up for. I didn't sign up to make a lot of dough. I didn't sign up to try to make the hospital a sleeker, faster, more money raising enterprise. And so for me, I think that all those arguments can be helpful. And the last one is this. Most hospitals already have some programs like this embedded. They already have a sexual assault forensic examiner nursing program, or they already have some domestic violence response programs, probably which are sponsored by OVW. Those may not be hospital-based, they may be county-based or state-based, but connecting with those programs and reminding them that older adults are crime victims, because often those appropriately focus primarily on younger adults and children, can be another strategy. So that's a very long answer for which I apologize, but does that help?
It's very helpful. Like we have a couple different hospital systems, and the one that I worked for was very small. Like the ER docs were not even their docs. They had to contract with like an ER physician type of place. So it was really, that was tricky too, because the more patients they move through, the more they get to bill. it's so like, I know that there's a lot of great doctors out there that care, and I worked with a lot of great doctors that care, but there was different motivations, I think sometimes, and different limitations, but I really appreciate, I think, the diversity of options. I like to figure out how to overcome barriers. And I think this has been very helpful. I appreciate the long answer. It's very comprehensive.
I get it. I don't get paid as much on what are called RVUs as many of my community colleagues, but they do. And, we need to remember, though, that this is a really, and I think this is how you pitch to the hospital, this is a small but very vulnerable and very high risk population. And we're right now not doing a very good job. And that can change without changing your salary very much, and without changing the running of your hospital too much. Alyssa and Elaine, anything to add to that unfortunately very long response?
No, I think that was very comprehensive.
All right, thank you, everyone. We're gonna leave the chat box open, and please feel free to stick around and keep asking questions. I just wanted to note that I did put the evaluation link in the chat box, so please click on that. Let us know how we did today, and also if you have any ideas for future presentations. And thank you so much. Nancy, did you have a question?
I did, and I apologize for getting a call right then. So I am very interested in trying to approach our hospital to start to consider such a response. Who would be, from your perspective, if I could only get 3 or 4 people in the room, who are those 3 or 4 people? You're muted, Tony.
All I said was good question, which I always say, but it is in fact an excellent question. I think that a couple of people here are the people that I think are most important. Obviously, if you can get someone at an administrative leadership level,
Right.
That's useful. That's often not possible. Ideally, you want you want someone that can be the champion for this program, and often that's social work. And so you might want either social work leadership or an ED social worker or a care coordination leader, because I think fundamentally they're the folks that are already dealing with these cases and are already going to give the kind of pushback that Ms. Hollenbach described. Well, we're already having trouble with these cases. And so part of the pitch to these folks is, we can help you with the cases that stay 55 days. We can help you with those cases. And that's part of the story. And I think that's part of the story that you can tell your administrative colleagues and the leadership folks when you talk to them. And so for me, administrative leadership, social work and care coordination leadership, and then an ED-based physician champion, ideally. And it might be hard to know who that is. But one of the things that I would recommend that you check is that right now, ERs are more and more applying for geriatric emergency department accreditation.
Mm-hmm.
I don't know whether your hospital is interested in that. Many hospitals have become interested in that recently. And if they are, or there is someone interested in that, then whoever is leading that effort would be appropriate. Otherwise, if there is a physician in the emergency department who either leads their sexual assault forensic team or somehow has demonstrated an interest in violence prevention, then that would be a good person as well. So I think from my perspective, a champion physician who has demonstrated their interest in violence prevention or in geriatric older adult issues. And for me, I think that those are the folks that you want. And then the reason I brought up that last person is that here's the other question that I want you to ask is, if you have a community-based multidisciplinary team, who from the hospital do you want to sit on that team? And that person you want in the room. And that person you want to think about how you can incentivize them to want to be involved in the team, to be the liaison between that ER and your community-based team. Does that make sense?
Yeah.
And so,
yes.
And then like all my long answers, I promise to stop the long answer. Often the head of the emergency department. So if you had two people, you have a physician in charge of the emergency department, and you have a nurse in charge of the emergency department. And those two people are often looking to hand off new innovative responsibilities to enthusiastic junior people.
Right.
And so in an ideal world, let's say I knew the chair of your hospital emergency department. Maybe I would call them and say, hey, we've got this really great opportunity, we think. Is there anyone that's junior, that's looking for projects, that has an academic interest, that is interested in violence, that is interested in geriatrics? That's kind of an approach that I might take. Does that make sense?
Mm-hmm.
Or do you already have someone in your group that has an interest in this area? Or maybe you are. But ultimately, what you want is to have both leadership buy-in and a champion on the ground.
Okay, thank you.
Helpful or not really?
Yeah, no, that's good. And how would I know that our hospital is doing some accreditation in geriatric surgery outcomes, trying to get accredited there. So I am familiar with that, and they actually asked us to be on that team, which was great because compliance with surgery,
Totally.
does abuse impacts that. How would I? Is there who runs like the accreditation for EDs, or what? Where could you point me for that to get a little information?
Good question. It's the geriatric emergency department accreditation is through the American College of Emergency Physicians, and of course I know the surgery folks as well. I was part of that as well, as you can imagine.
Okay.
Hold on just a second. Let me see if I can get
Yeah,
it.
no, I think that's helpful. I think we do have a desire to want to be accredited in every department. So thank you for pointing that out.
I think that's the angle.
Yeah, I like that.
That's the angle. And also for you to know, because I, particularly with your work on geriatric surgery, I'll also put one more thing in the chat, since you brought up surgery, and then I promise to stop.
It's great.
This is every year the American College of Surgeons, which is the group that does geriatric surgery accreditation, does best practices for trauma. So I don't know if any of the hospitals that you guys work in are trauma centers, but in fact, if you see that what I put in there is it's last year's or now 2 years ago's best practice guidelines for trauma centers. And the topic that they focused on was child abuse, elder abuse, and intimate partner violence. And so trauma centers need to be focusing more on these topics this year than they were in previous years for their accreditation process. And so that may be another way into the hospital. And also, Ms. Aiken, if I can be helpful, these guys have my email, reach out to me. I'm happy to try to make a connection or give a talk if that's helpful, and so on and so forth. It's much easier. We used to say, oh, I can travel and give grand rounds there. Now you can give grand rounds from your basement. So, so if I can be helpful or we can be helpful, let me know.
No, that would be great. I will probably take you up on that.
Everybody have a great afternoon.
Thanks so much.
Thank you.
Thank you all so much. You have a great rest of your day.